Hello everyone. This course is a part of the project funded by the European Union and Russian Federation. The name of the project is Promotion of Breast and Colorectal Cancer Prevention Measures in Cross-Border Territories. The name of the course is Fight with Colorectal Cancer. My name is Denis Shimchikas and I work at Day Surgery Center of Republican Klaipėda Hospital and in Klaipėda University. This is eighth and the last episode of this course, and I would like to continue my talk about the performance measures in colonoscopy in our everyday practice. For this talk, I'm using this guideline as a frame, and this guideline was published in 2017 by European Society of Gastrointestinal Endoscopy. The authors of this guideline divided pericolonoscopic period into 7 domains, where each domain has one key performance measure and may have few minor performance measures. In previous episode, I was talking about the management of the pathology, and in this episode, I would like to mention few sentences about complications, patient experience, and post-procedure surveillance. Let's start with complications, where complication rate is a key performance measure. According to the guideline, complication rate is a percentage of patients in which complications, immediate 7-day readmission rate and 30-day mortality rate occur after screening, diagnostic, or therapeutic colonoscopy. Why it is important? Monitoring the rate of complications after screening, diagnostic, and therapeutic colonoscopy is important to assess the safety of procedures, to identify possible targets for improvement, and to allow accurate, informed consent of patients. There should be record for following parameters: early complications, adverse events, and harms, 7-day readmission rate, 30-day readmission rates where there are reliable registries and sufficient resources, and 30-day mortality rate. Assessment should be done using a reliable method that allows identification of immediate and delayed complications, such as direct contact with the patient, analysis of hospital records, analysis of registries. Minimum recommended standard is less than 0.5% for 7-day readmission rate, standards not set for 30-day mortality rate or immediate complication rate. There is no target standard set. Endoscopic reporting systems should allow the reporting of early in-hospital complications, including the type of complication, description of any action relating to the complication. For example, need for transfusion, hospitalization or prolonged hospitalization, surgery, death, need for endoscopic re-intervention, and time for endoscopic procedure to onset of the complication. Some studies and guidelines have reported rates for specific complications such as perforation, bleeding, or sedation-related cardiopulmonary adverse events. The all-cause 30-day mortality rate is certainly well defined and important to measure. In large clinical or administrative databases, the rate of all-cause 30-day mortality has been estimated at 0.07. That means 1 in 1,500 cases. And the colonoscopy specific mortality at more than 10 times lower. That means 1 in 15,000 cases or lower. In our day surgery center, after 450 colonoscopies, we had complications as follows. Sedation-related cardiopulmonary complications, 2 cases of paroxysmal atrial fibrillation. In both cases, cardiac rhythm went back to normal after intravenous fluid infusion and patients were not hospitalized. We had 2 cases of bleeding after multiple polypectomies. 1 patient was hospitalized for monitoring. No interventions or no blood transfusions were needed. And talking about the perforations, we had none. In my personal clinical practice in 10 years, I had 2 perforations. One was after polypectomy and one was after colon necrosis because of impaired blood flow of the colon after colonoscopy. Talking about complications, here again ESG gives us a helping hand with a beautiful guideline, actually with beautiful position statement, which was updated in 2020. And its name is Diagnosis and Management of Iatrogenic Endoscopic Perforations. Now let's move to next domain, patient experience. Patient experience during and after colonoscopy and sigmoidoscopy should be routinely measured and self-reported by patients using validated scales. It is important because colonoscopy can be an unpleasant experience. Moreover, there are considerable differences between endoscopists and between different sedation modalities with regards to patient-reported pain and discomfort. Patient experience and its improvement is crucial for the acceptance for procedures. After all the colonoscopies, patient experience should be measured with scales like the Global Rating Scale, the GastroNet, or others. Minimum recommended standards are known. Target standard is more than 90%. Currently, there is no standard approach to measuring patient experience. Different questionnaires are available and their comparative performance is unclear. Ideally, patient experience should be self-reported using a standardized and validated reporting method. Audits should be performed on both service and individual endoscopist level to assess patient-reported outcomes. In case of substandard results, for example, if one endoscopist performs worse than others in the same service, additional training and feedback should be considered. Colonoscopy may be perceived to be painful and embarrassing procedure, and this perception hampers patient participation in screening programs, adherence to surveillance recommendations, and even diagnostic work up for large bowel symptoms. Although sedation may decrease pain during colonoscopy, it does not eliminate it, has little effect on post-procedure pain, and increases the risk of complications. Therefore, monitoring patient experience including intra and post-procedure pain levels is crucial. The two most widely used and validated questionnaires for assessing patient experience are the Global Rating Scale and the GastroNet. The two main validated scales for pain assessment are Visual Analog Scale and 4-point Verbal Rating Scale. 3 studies have shown similar sensitivities for these scales. In our day surgery center, we look forward to use standardized questionnaires to track patients' experience, and in general, how we track our complications and patients' experience is that we have a service where nurses call after a few days and ask the patients, is everything all right? Besides, patients have our direct contacts in case anything goes wrong, and also they are told to go to our hospital if they experience any health issues. And they are not only told, but also there are given written recommendations as well. And the last domain is post-procedure, and the key performance measure is appropriate post-polypectomy surveillance. Adherence to post-polypectomy surveillance recommendations should be monitored, and the reason for deviation from national or European guidelines should always be provided. It is important because post-polypectomy surveillance recommendations reflect the best evidence-based balance between benefit and harm. Too frequent surveillance wastes resources and exposes patients to complications of an invasive procedure. Too infrequent surveillance may limit the effectiveness of surveillance. Target standard is more than 95%. All endoscopists should follow national or European guidelines for post-polypectomy surveillance, and any deviation from these guidelines should be clearly stated. When no written recommendation is given, this should be treated as a missing recommendation. Endoscopic reporting systems should contain data about surveillance recommendations issued to the patient. Unfortunately, studies from the Netherlands and Canada have shown that less than 30% of patients who have undergone adenoma removal receive appropriate surveillance. One of the key reasons of inappropriate surveillance is inappropriate recommendations given by gastroenterologists, surgeons, or primary care physicians. And again, here comes ESG community with beautiful guideline, which was updated in 2020. And for proper post-polypectomy colonoscopy surveillance for your patients, I highly recommend to read this guideline, Post-Polypectomy Colonoscopy Surveillance. So, in our everyday practice, what I do is I get histopathological report from the pathologist after the polypectomy. Then I perform a distant consultation directly to the patient. It means that after 2 weeks I call him. I ask the patient, is everything okay after the colonoscopy? And depending on histopathological report, I give them to the patient the recommendations about the appropriate post-polypectomy surveillance. And what happens then is again new circle of workflow, new consultation, new indications, and etc. So here I would like to finish this course where we talked about the colorectal cancer, about precancerous lesions, and about colonoscopy performance measures. And I think we all agree that colorectal cancer is not that nice as it sometimes looks for artists, and and that we have all possibilities to fight colorectal cancer. Being aware about it and having the colonoscope and additional equipment for finding precancerous lesions and removing them on time. I would like to thank you very much for your attention and I wish you all the best. Bye bye.